Right, good morning everybody. My name is Scott Horban. I'm a senior data engineer from the Health Informatics Centre based in the University in Dundee in Scotland. Today I'm going to talk to you all about our involvement with the EHDEN consortium over the past year, as well as our participation in the first Evidence-a-thon that Danny has just kindly presented over as well. First and foremost, a bit about HIC and Dundee. So Dundee is a city in Scotland. A picture you can see on the left there shows the different regions within Scotland. And we hold healthcare data about patients from the Tayside and Fife regions of Scotland. So these sections highlighted in yellow here on the left-hand side of the screen. I've also included some pictures of the city of Dundee on the right-hand side. Hopefully you can see how nice of a city it is when the sun is shining like it is today. A little bit more about the Health Informatics Centre. So we cover the sort of areas shown on screen at the moment. So that ranges from the likes of study feasibility searches, governance, data linkage. We even have a data entry team and a software development team who develop software programs like the RDMP software, which I'll talk about in a few slides' time. I see. Okay, sorry. So here's a little bit more about HIC. We've got a large-scale support and automation for research service. We've supported over 180 million of total grants over the past 5 years. 600 research projects and multiple other points that you can see on screen just now. EHDEN is the first project of its kind that we've participated in, so it was quite a challenging and interesting project to work on, and something new for us as an institution. Again, this slide covers some of the stuff we've already spoken about. So we've got the Tayside and Fife regions of Scotland. It's about 20% of the population of Scotland, which is about 800,000 living patients, if I remember correctly. And that figure increases a little bit to around about 1.25 million if we include patients who are deceased in the time that we look at for the OMOP model. We hold data all the way back from 1962 up to 2021, but for the OMOP model we decided to take only our data from 2009 onwards, since that's when it becomes most complete. So I'll talk a little bit about our source data before we talk about the EHDEN specifics. So the main data sets that we considered for conversion to OMOP for the EHDEN project were as follows. So we've got the Community Health Index, or CHI data. So this mainly covers the likes of patient demographic data, so age, sex, as well as some address and location data, as you can see in point 2. We've also got patients' GP surgery details recorded on the CHI data, so we can see where they were registered with their GP. And we also included location information from hospital and other clinical services under point 3. Point 4 is a family of datasets called the SMR, or Scottish Morbidity Record datasets. So as you can see in the list below, these range from outpatient hospital, inpatient hospital, and other services through to the cancer registry dataset as well. Under point 5, we've got a variety of different lab data fields. So these range from the likes of biochemistry and hematology through to virology, which is particularly interesting for COVID-19, and immunology too. And finally, one of our biggest data sets actually is the GP prescriptions data set. So that is any written prescription by a GP in Tayside or Fife that is handed out to a patient. So I'll talk a little bit about the timeline of HIC and EHDEN now. So we first applied to become a data partner in late 2019 before the COVID-19 pandemic began. In early 2020, we also applied for additional support under the COVID-19 call. So this involved some extra funding, I believe, as well as some work, some closer interaction with some of the EHDEN experts. In particular, we worked closely with Erica Voss and Peter Reinbeck, who were both extremely helpful and professional in their dealings with us, and were, very responsible for us delivering our conversion to the timelines that we did. It wouldn't have been possible without their close help. So we actually began working on our ETL conversion process in about June 2020, and we'd largely completed this by February 2021. So that's about 8 months or so it took us to convert all of our data. We were then validated by an external SME company called Imosphere. And although that process took a couple more months, we were able to fully be completed by July 2021. As you saw in Danny's slides just before, we participated in our first research study in July 2021, and continued on to participate in the Ethon as well. So here are some of the record counts of our OMOP target tables after our conversion. You'll see that if we include the vocabulary tables in these counts, we've actually got over 1 billion records in our OMOP database, with the measurement and drug exposure tables taking up, a fairly large chunk of those record counts. Our ETL is structured using that piece of software I described earlier called RDMP. So this is an in-house ETL tool developed by the software engineers who work for HIC. Each data load loads one or more OMOP target tables. So you'll see that we've split them into 6 data loads, including a part 0 for the vocab tables. These data loads are ran in order to make sure that our OMOP model doesn't get out of sync. So, for instance, the person table has to be loaded after the location table since it has a foreign key dependency on it. We've also got structures in place to prevent that from ever happening. So if you try and load part 3, which corresponds to person and visit occurrence, before you've ran part 1, it will essentially just not do anything until part 1 has caught up. I'd like to talk a little bit about performance quickly as well. So first and foremost, these data loads are set up to run with an initial or alpha load. So this loads all of our historic data over the years and generally takes quite a while, say 3 or 4 days usually. However, after we've done the initial load, the data loads are configured to only process the incremental changes or delta loads going forwards. So each of these delta loads tends to take around about 2 hours, and we run them on a monthly basis. So we're quite proud of that performance. Okay, the 3 or 4 days to completely rebulk the database is quite slow, but 2 hours to update it every month, that's a really manageable performance. We also can schedule the RDMP data loads using a scheduling tool called Jenkins. So in terms of the studies we've participated in so far, we've got 3 on the slide here. So there was the COAG background incidents, which focused on certain blood events, as you can see under point 1. I believe this was actually closely related to point 2, which is the adverse events of special interest, or the Ethon, which Danny has covered way more thoroughly than I'm going to cover in this presentation. And we're also currently participating in ECORE, which is looking into the performance of corticosteroids like dexamethasone when treating COVID-19 patients. I'll skim over the Ethon stuff since Danny has covered it so thoroughly, but we participated in the Ethon ran the associated R packages, so that was the Cohort Diagnostics and the incident rate package. And it was focusing on the likes of deep vein thrombosis and thrombocytopenia. The section of the Ethon that we found particularly interesting was the in-depth tutorial on the Cohort Diagnostics package. So previously we had ran this package a couple of times on the previous study that we had taken part in, but we hadn't really known too much about what Cohort Diagnostics was designed to do. We found that the sections of the Ethon which focused on this really helped us to understand what it could be used for and how powerful it is in relation to exploring the sort of data that we hold and how it's brought out when looking at a particular research package, for instance. One more point on this slide. So what we found, which was quite interesting, was that if you look at the numbers shown here on this slide, we actually have over 100,000 patients who have at some point had a platelet count measurement less than 150, but only around about just over 1,500 of these patients were actually given a formal diagnosis of thrombocytopenia. So we found that really quite interesting, that so many of our patients in our data set technically fall under a definition of thrombocytopenia, but so few of them are formally diagnosed with it. So again, that just speaks to the power of the Cohort Diagnostics R package. So finally, the output of the incident rates package is shown here. So it was a very straightforward output to read and understand. I'm not a statistics expert by any means, but even I was able to have a look at this and understand what the incidence rates were referring to for the different outcomes and cohorts. HIC were a little bit late in sending our results to the likes of Danny and EHDEN for inclusion on the paper, so I don't think our results were shown very much in the previous slides, but that was because our governance was still moving forward at that point. So now that all of our governance is through, we hope to participate in future studies and be able to share our results on time. So looking to the future of HIC and EHDEN, we're planning to hand over the running of the studies to our internal research team, and we hope that they'll be able to provide more input to these studies from a research perspective, rather than our areas of expertise, which are more towards the data engineering side. That being said, once we've handed over the running of the studies, which can sometimes be quite time consuming, over to the research team, we're going to focus on including some more of our source data into the OMOP model so that hopefully we can participate in a more diverse range of studies in the future. So for instance, we have a very detailed diabetes register data set that we're looking to convert and incorporate for any studies interested in diabetes. So to sum up, that was HIC's experience with the EHDEN project over the past year and a half.